say a patient who's young comes with hypertension. Okay, patient got elevated blood pressure. They're giving a young patient really high blood pressure, drug resistant hypertension, right? Most young people, when they come with hypertension, do you call it primary hypertension, or are you supposed to look for secondary causes? You're supposed to look for secondary causes, right? So when you think about secondary causes, what are some of the causes you would think about with relation to your adrenal gland? What's that? Pheochromocytoma is one of them. Good. What else?
Addison.
Huh? Hyperaldosteronism is another one, right? So let's do hyperaldosteronism first, okay? So whenever you suspect that somebody's got hyperaldo, right? First off, where is aldosterone produced from? Very good. You're jumping the gun before me. I like that. So glomerulosa, fasciculata, and reticularis, right? GFR, right? Glomerulosa produces aldosterone, right? Aldosterone. Now, when you think about aldosterone, why is aldosterone produced? What pathway do you have to stimulate first to get to aldosterone? The RAS system, right? So typically, when do you stimulate your RAS system? When somebody is hypotensive, right? If you're volume depleted, then you'll activate your RAS system. So basically, you first off need angiotensinogen, right? You need angiotensinogen, which needs to get converted to angiotensin 1. By which enzyme? When it comes to hyperaldosteronism, what we are most interested in is this pathway to stimulate aldosterone. What does aldosterone do? It reabsorbs sodium in water and pushes out and excretes H plus and potassium. So what would happen? You would get hypernatremia, you'll get hypokalemia, and a metabolic alkalosis. That's what aldosterone is going to do, right? Now, if you're suspecting a patient's got hyperaldosteronism, you would almost imagine you're going to look for that in the labs. You're going to look for that hypokalemia and metabolic alkalosis. But if somebody is dehydrated, you would expect to see that anyways, because your RAS is getting activated. So don't always expect to see that, because it doesn't always happen. The hypokalemia, metabolic alkalosis might not always happen. Just because it's not there doesn't mean you can rule out a hyperaldo. If you want to suspect the patient's got hyperaldosteronism, what are you going to test them for?
Renal.
Okay, you want to get renin levels or something else? Okay, so what you want, so let's put it this way, okay, because most of the books don't explain it in this way and I think it gets confusing. So let's keep it very simple. So greater than 20 is your ratio and plasma aldosterone concentration needs to be greater than 15. If you had this, now you've diagnosed the patient of actually having hyperaldosteronism. Make sense? Too much aldosterone, low renin activity. Two numbers, 20 and 15. Okay? But the boards are evil. Why? Because they know that you know this answer. So what they're going to tell you is the patient is on an ACE inhibitor or the patient is on an ARB, and they give you this patient and they're going to ask you, what are you going to do now? So what's going to happen? Let's think about it logically, right? If you're giving somebody an ACE inhibitor or an ARB, what are you blocking? You're blocking this step, right? So if you block this step, what would happen to aldosterone? So you're like, okay, great, so I know that. You should feel good about yourselves. But the boards are still evil. So what they're going to tell you next is, what if your patient is actually on an aldosterone blocker? Such as... Okay, now, once you've biochemically proven that the patient's got hyperaldosteronism, meaning the adrenal gland is producing too much aldosterone, do you know which gland is producing too much? Do you know if it is this gland or this gland? You can do a CT scan and look for an adenoma. What are the most important causes why it happens? One of the most important reasons is congenital adrenal hyperplasia. Remember your 21 alpha hydroxylase, 17 alpha hydroxylase, 11. The one that actually produces too much hypertension is adenoma, right? So you can do a CT scan of the adrenal glands and say you see an adenoma, great. Or say you see nothing, right? Just because there's an adenoma, do you know it's hyperactive? You don't, right? Because you want to make sure you remove the right adrenal gland, right? You don't want to remove the wrong adrenal gland. So what do you need to do here? Do. But if somebody is a poor surgical candidate, then how are you going to treat them? What blocks aldosterone? Spironolactone and eplerenone. So you can actually do medical therapy if they're bad surgical candidate. If they say, oh, the patient is really old, has multiple cardiac history and whatnot, and you don't want to do surgery on them, pick medical therapy, spironolactone or eplerenone is what you're going to do.